over to
Okay, thank you, Sylvia. A very good afternoon to one and all, and warm welcome to the sixth session of our course. Last session, we had communication, how to communicate with patients and what are the difference and what are the methods we used. I hope that session was very useful for everyone and the doubts and everything has been cleared, I believe. And today, as senior said, we have a very good personality joined us as a faculty for the topic communicating bad news and collusion. And in today's session, we'll be discussing the prevalent models in communication and the need of communicating the collusion and bad news. Moreover, dealing with emotions and dealing with pollution. These are the points that we are going to discuss. And let me introduce our faculty, Ms. Priyadarshini ma'am. She is the ex-medical director of Sipla Palliative Care Center, and she was associated with Palliative Care Center Pune, and she was a consultant physician there. And she is also leading the Indian chapter of Elizabeth Kubler-Ross Foundation. And she has also written a book in the name of Touching Hearts Gently. So I think moreover details, we are not clear about the details more than that, but she is a very active person in the field. And welcome you, ma'am, with with everyone's we welcome you to this session, and please, over to you, ma'am.
Okay, thank you very much. Should we straight go on screen share?
Yes, ma'am.
Yeah. Okay, everybody is able to listen and see?
Yes, ma'am, we can see.
Okay, so let's start without wasting the time. Thank you very much for giving me this opportunity to be a part of this group and share my experiences. I hope this session will be as interactive as possible. Because I have slides, I may not be able to see if you have raised hands or something. So stop me anytime if you feel like. And let's try and see what we can learn about breaking bad news in palliative care settings, and what about collusion and how to, work towards that. I understand that many of you are counselors or medical social workers, but there are also few doctors. And I also understand that few of you have had some training in palliative care, but majority of you have learning about these issues for the first time. That's right, Senior?
Yes, ma'am.
Yeah. Okay. So just to have a recap of what you learned in basics of communication, we are not going through all the details, but whatever is important for us, skills required for good communication is basically thinking, listening, speaking, and even understanding non-verbal clues or cues. Right? And I'm sure you must have had some case studies for discussion or whatever when Dr. Miss Madhura took the session. So why do we all learn about communication in medicine? When we were training ourselves to be doctors, there was no subject of palliative care, so there was no subject of communication at all. But newer batches now, they are getting trained briefly about how to talk to families, how to break the news. And I think this is important for each and every one of us, whether you are a doctor, a nurse, or a social worker, or anyone in the community, because even if you are not medically related person, a time comes within your family, within your friend circle, where you have to break the news. Right? And therefore, this is very, very important. So why do we talk about medical communication? What is the aim? It basically enhances the therapeutic nature of medical encounter. What's going to happen now? It, if you have a good communication, it reduces the uncertainty and improve outcomes of care. You know, I would give you an example. We had a young girl who had breast cancer, and there were metastases as well. And she was very, very tired and upset with life and didn't want to take any further treatment. She had met oncologist who has advised further cycles of chemotherapy. But this girl was feeling that, okay, there is already a metastasis, so my life is in danger. I'm not going to survive anyway. You know, this surgeon and a medical oncology team I work with, they just told me, because the patient is very young and not really agreeing for the treatment. We all know that majority times breast cancer, if treated, if diagnosed early and treated aggressively, can be potentially curable. So they wanted me to talk to them. And when I took her time and I went and sat next to her and understood what she was going through, you know, her mother also had a breast cancer and her aunt also had a breast cancer, but that was many, many years back. One of them took treatment and the other didn't take the treatment, but both suffered terribly. They had a lot of pain, and all those impressions were there in this girl's mind. You know, when I heard her out and I then told her how the treatments have changed, how the medical speciality, as you know, oncology has developed and developing medicines each year, which is coming with less side effects and all, she agreed for the treatment, and today she is much better, I should say. So it helps to reduce uncertainty. I didn't do anything else in this case apart from talking, basically listening to her fears and then trying to tell her how things have changed. You know, good communication improves patient satisfaction as well. It helps to prevent inappropriate hope and guilt in terms of, like, if you have a family member who thinks that should I have done this or not, if you have a clarity in the communication right from the beginning, all those things are very clear during the course of the disease. And to prevent conspiracy of silence, we often use this term conspiracy of silence to say that, you know, everyone knows what they are going through, but nobody wants to come out and openly say it. That's conspiracy of silence. Is it a okay pace? Is everyone following? Hello?
It will be better
Yes,
if
yes, ma'am.
everyone switch on their videos as well.
Sorry?
It is requested that the participants could also switch on their videos so that we can have a live session with them, and it could be more interactive. So
Yeah,
please.
that's what I am facing. Somebody has raised the hand. Can we ask that person? Somarthu.
Somaratu Shiva. Hello.
You can continue, ma'am. I can-
Okay. Yeah, fine. So, but they can stop me anytime. Yeah. But the pace is okay, right?
Yes, ma'am.
Yeah. So what happens if there is a good communication and a bad communication? If it is not proper communication, then it can lead to a range of negative emotions like shock, disbelief, numbness, guilt. This happens in patient, like, you know, we all know if a doctor is in a hurry and he comes and tells you quickly that your mother or father has so and walks away before you even register those things and want to ask further questions, then what would be your reaction? Whereas if you have time and you sit down with them, take a separate time out, then it will lead to a stronger and trusting relationship between doctor and a patient, or between doctor and a caregiver, right? So I'm just showing couple of good and bad communication things. I'm really missing being face to face. But if the patient says, "Doctor, I don't feel too good," and doctor says, "You have not followed my instructions, I can see that," how does the patient feel? You can think about yourself. He might just stop communicating with this doctor. Instead, if the doctor says, "I can see that too, that you are not feeling too good. Tell me what is troubling you. What's happening here?" Rather than shutting him or her off, you are putting an open question that might give him a window to open or explore his fears or thoughts to the doctor, right? Another example, "Doctor, I am unable to sleep at nights." Immediate answer is, you must be sleeping during the day. Or take diazepam and you will sleep well. Will it satisfy the patient? No, because his or her reasons for sleepless nights may be more serious. And we need to explore that. So instead of all this, if the doctor says, "I understand it must be frustrating not being able to sleep. What has been troubling you, or what are you thinking when you're awake?" See for yourself if a doctor talks like this, and I'm putting it here, doctor, because I'm a doctor, but you can put yourself as a counselor there and again see how the communication goes on and what's the impact of that communication, right? So coming to today's topic, BBN is breaking bad news. So how do we define bad news? We all are used to having bad news, like since our fourth standard or seventh standard or 10th standard, when we get the results and our results says that the marks are not as per our expectations, or we are going on the new two-wheeler which your parents have given you and you go and dash it to somebody and then there is a problem. You know all those bad newses, right? And you have, many of you have handled with those kind of things. The most of the times what I had to tell coming back home and telling my family is, I forgot my mobile somewhere and I have lost it. But those things are different. And when it comes to, dealing with life and death and talking about bad news about your diagnosis, prognosis, how you're doing, it's totally different. So what is bad news and what is breaking bad news? That any information which we give that adversely and seriously affects individual's view of his or her future. The world comes shattering after hearing those news. That is bad news, right? So do we need to learn about it? I'm sure many of you had faced such situations in your life, but is it really need to be learned, or whatever it is, and you have to deal with it? What everybody is thinking? Anybody wants to share, contribute? No? Okay. So why we need to learn about breaking bad news? You can see a egg here and you can see a egg here. Do you see the difference? In the first picture, it's all messy there. And in second picture, it is all very clean, neat, exactly broken into two halves, right? So breaking bad news, it's similar to breaking an egg. A certain amount of skill is needed. Otherwise, you are liable to make a mess. And when it comes to somebody's life and death, Who would want to make a mess? Any thoughts? I think this class is very, very silent. We need to do something. Hello.
I think one of the reasons we do have to break the bad news so that the patient is, sorry, I have a bad throat. The patient is aware of the prognosis and he or she is prepared for the remaining part of her or his life.
Yeah. Thank you, ma'am, for sharing.
I'd like to say something too. When you
Sure.
look at the egg,
Sorry.
when you look at the first egg,
Yeah.
there are a lot of cracks. So it's not only one person that it affects a lot of people, and each crack affects like each crack is a person being affected. And overall in the whole, I don't know, household, family, friends, everything just spills out in a very unclear, difficult manner. It's like that.
What's your name, ma'am?
Isha Bistal.
Okay. Thank you very much for adding on to that extra bit to this picture. Thanks a lot. At least it gives me a feeling that you're processing as you're listening. Thank you. So, we normally take this as a role play, but we'll just read it together. Imagine that you are a general practitioner. You have seen a patient about a week back for mouth ulcer, which has not responded to your treatment. You advised him to go to a surgeon who then did a biopsy. Patient has come to you with a biopsy report which reveals cancer. How will you disclose? Any doctors in the team? Anybody wants to try?
Ma'am, there is a chat from Gopa Mukherjee. That in my mom's case, I discussed about the tumor she had, Then I said, since she has a family history, she has to be taken for PET's CT.
Okay.
And from Shiva Majumdar, I may say that I am afraid the report is not looking very good.
Okay. So you mean to say, first of all, you will tell them that there is something which is coming or following, which is not good, right?
Maybe when you say it might be cancer, when you send the piece for investigation itself, you've
Possible.
told him that it might just be cancer.
Possible.
So I think there itself, a little bit of bad news has been broken if it comes positive, because now they know there is a chance. And when the report comes back, they just want to know whether it's there or it's not there.
Ma'am, first we
When
have
you say the report is not good, they know what it is itself. And
No,
nothing-
but the
ma'am,
yeah.
ma'am, first we have to invite the patient at her or his comfort.
Okay.
That I have to discuss about your reports tomorrow or whenever you need. Then we have to set the environment, setting as well as for the family members. So we have to set the environment, we have to put the chairs, and we have to invite everybody. And we have to talk separately with the family and the patient. How do you
Okay.
know or how much you know about this disease or whatever, and then the past history, how he or he has been. Then we have to know about the mood of the patient. And then we have to slowly disclose report to his or her. And then we have to see the emotions and we have to let it go. If the patient releases any emotions or the family members, and then we have to tell slowly.
Okay. So for the first person who said that before you send the person to the surgeon and say that it might be cancer, Yeah, I would like to say that it might. I mean, depends on your relationship with the patient and the family. But in the first go, without even checking, if you say that you might have cancer, there is a likely chance that they may not come back to you anytime after that.
I said that, but don't we have to say that we are sending for investigation instead of saying you might have? We will have to inform them that we are sending to check, to do a biopsy, which itself, a lot of people will know that it's for cancer.
Yeah, I mean, I get your point, but I'm just trying to make you aware that, without having evidence in hand, if we say that, it might create anxiety at a different level. So probably what you can say that, since the treatment has not really worked, I want to make sure what this is, and therefore we are doing biopsy.
Yeah.
Will that be okay?
Yeah,
Yeah,
it sounds better
so-
also.
So, it's tricky all the time, and you have to use your words very carefully. So let's see, if we say that your report says that you have cancer, get admitted and let us see if treatment is feasible. What's going to happen? Patient is totally shattered. Or if you say that I'm sorry, you have been diagnosed with cancer, perhaps it has already advanced, and I guess we don't have much treatment to offer. I'm afraid you have only 3 months to live. You have given all the correct information. But the impact would be patient is upset and lonely, right? So why it is so difficult? I mean, coming to real life scenarios, look at this picture. You are always, however ideal it might sound, you are always within this mess. One side, doctor is there, nurse is there, patient is there. There are multiple patients crossing. You're in the corridor. You don't have privacy. In the meantime, you're getting phone calls from n number of different people, very, very important. And you want to shut them off. You want to talk to them. You want to give this news. And, then you are giving this difficult news in the middle of all that. So these are environmental barriers. Why it is difficult even to receive such news for patients or families? They naturally feel that doctor is too busy, or they don't know how to ask to a doctor. Probably sometimes they know that it might be cancer, but they don't want to face it. They feel that doctor is more interested in the physical care and do not want to know of their emotional problems. Maybe counselors are there for that. It's their assumption. They're frightened of breaking down in front of us. And if they ask more and more questions, sometimes doctors also have their own inhibitions in explaining, and patients or families fear that they will stop treating them. Any more difficulties on patients or families' behalf? Any thoughts? If not, then we go to what happens to professionals when you have to first break the news. When I was very, very young, and I'm basically anesthesiologist, and my job was to save lives before I became palliative care professional. And when I joined palliative medicine as a full-time profession, I had to many a time stand next to patient's family, seeing death happening, supporting them. And when I had to go out and tell the family, rest of the family, that your loved one has passed away, I used to be frightened like anything just to explain it to them. And why? I didn't want to be the messenger of something very bad for their life, so that they will remember me in a bad way all their lives. I'm sure you all may have stories, some remembrance of, news broken in a particular way, which was nice or not nice. But for professionals, sometimes it is fear of getting blamed, or it might be like letting their patient down. What if patient's family asks difficult questions? What if they start crying? Or what if they start getting angry? I remember a case in our ward earlier, many years back actually. Young child was dying and he had an older brother who had gone to school, who used to come and meet him every day. But the day on which that child died, this boy, young elder brother, was called for from school. And when he came, he started throwing tantrums to the extent, as he saw his brother, younger brother, not breathing, he really became violent and he was angry. And the most anger was towards me because he thought that I would be the person who would save his brother. Sometimes they have very high expectations from us. And when we don't fulfill, it is very difficult to face them. Responding to them, like if somebody talks to you angrily, you might also become angry. Not in this particular case, but when it happens as adult to adult. Sometimes, as professionals, we want to protect the patient or the family. What if I tell the patient that you have cancer and they stop eating? Has anyone thought like that? Sometimes we feel that as doctors or professionals in healthcare, we have all the power, and we feel awkward to feel that powerlessness. And as I said, in the BG hospital, sometimes we don't have enough time. The other thing which we are going to see later part of this lecture is sometimes family doesn't want it to be revealed to the patient. So it is again difficult. So what we do as a professionals, we use distancing techniques. Non-verbal, we don't look at them. We show that we are always busy. No facial expressions to show our emotions. And we try and see that we are concentrating on physically caring for the patient, not really talking to them. We sometimes end up labeling them as a difficult patients. And we also never really ask them beyond their physical symptoms, like, how are you feeling today? If they are telling us something as their queries, their real fears, we change the topic to the other thing and say, but your pain is better, isn't it? Or a premature reassurance. Sometimes we would say, don't worry, I will handle it. I have known senior doctors who really talk a word or two when patient really expect them to say a couple of sentences. Or I have seen people who just tell everything possible, minusing what is very important for them to know. Sometimes, in order to lighten the situation, we use inappropriate humor, and that's the worst thing, I would say. So, any thoughts at this point? Okay.
I was
Yeah.
just wondering how. Sorry, am I audible?
Yes.
I was just wondering how you personally would break this news to someone, and also, given that the number of cases is constantly increasing, how would oncologists manage, this need to go beyond just clinical information and also manage their caseload at the same time?
Yeah. So the first part of your question, we will go to the steps, how we are going to do that. And the second is what we are trying to do is to train our oncology colleagues how to do it. That's the task we are doing for few years now, and we can see the effects of it. So we are getting, as a doctor community, we are getting better and better at it. Very, very hopeful. Yeah. So importance of learning to break the bad news is to maintain that trust, to prevent inappropriate hope and guilt, to allow appropriate adjustments and to prevent conspiracy of silence, as I said. So imagine any situation where you have to break the bad news, any situation. And because we are not in face to face, I would leave it to you to think as we go step by step, right? So it's a 6-step protocol for breaking bad news. First is getting started. Second is find out how much patients know, then how much they want to know. Like, many a times village old ladies, typically when we are trying to talk to them, they will say, talk to my elder son. They don't want to listen to it. They don't want to comment about it. They are not part of decision making. They are just there as their family is directing them to do. Then sharing the information, taking the responsibility of patients' feelings, and planning and following it through. So I'll give you a couple of seconds to read through all these steps before we go one by one to each step. So you know that the news you have to break. How would you do that? You just saw that picture in a busy OPD. Do you want to break the news in that type of a setting? No. So how would you start preparing for that? First step is plan what you will say in your mind. You need to know for this, for doctors, you need to know what the biopsy report is. In medical terms, in detail, what it means and how you are going to say this to patient or family if they are non-medicals. Then you will have to ask them appropriate questions. Like, for example, referring to the same case, I had sent you to the doctor for the biopsy. What did the doctor tell you? Sometimes, surgeons who have seen the lesion and taken the biopsy, they might have told them that I want to rule out cancer. So if you ask appropriate questions, they might say, and your job becomes suddenly easy because they know it could be a possibility. The first one, you were saying Ishita or somebody, you were saying that why don't we tell them? But here we are like Isha. We are general practitioners, and like if I say I am sending you to a surgeon, maybe surgeon would have said, and you need to find out through appropriate questions. Then create that conducive environment. You need to set out that separate time, a separate place where you will have privacy. You will have enough time in hand. Not one day you have to break the bad news to 10 patients. Maybe it is one patient and you have to allocate that separate time for doing that. Then you have to decide to ask the patient or the family, who do you want with you? These are very small things which are very, very important. They may say, no, I'm alone is enough. Or they may say, I want to call my husband or want to get my son here or whatever. Yeah. So when we want to find out how much patient knows, how will you find out? Any thoughts? Again, learning from basics of communication. Don't ask them directly, what do you know about your disease? They would say, you tell me, doctor. Then you're again stuck at the same thing. Sometimes they may answer, but the best way to tell them, okay, tell me how it all started. You will give them an opportunity to speak. It's again an open-ended question. Then once you know what patient already knows, It may not happen in that short span. It might take 4 or 5 minutes to listen to them. And I'm sure Madhura madam must have talked about active listening, using all those verbal and non-verbal cues. You are actually into that scenario when you're listening to them. Then once you establish what they already know, then we have to assess the ability to comprehend new bad news. And how will you do that? After listening to all this, before you talk, you will say, well, I need to talk to you regarding the same. Is it all right if we talk now? Give them that option. If they want to say, no, not now, you can speak to my XYZ or whatever. So that is called as giving that warning shot. Okay. Then the third thing is how much patient wants to know. Many a times, people are different and they have different ability to cope with the situation. And you will, I don't know whether you are going to learn about denial and anger and all those things in this course curriculum, but they respond to these things very differently based on their previous experiences, based on what stage of life they are in. It's very, very different. So we have to give them that option, whether they want to know everything what is happening with them, or they just want to know whether they are going to be living for some time, or their quality of life is going to be how it is going to be, like what they are looking at from us. So for that, we need to recognize and support various their preferences. We cannot be going with our agenda that, okay, I have to break the news and that's all, the work done for today. No, because they handle this information differently. What if you tell the patient, a lone young patient, that you have a metastatic cancer and she doesn't even reach home? Who takes the responsibility? So once you know that,
Ma'am,
yeah,
how will we know if the patient wants to know or not? How much the patient wants to know?
yeah. So as I said, that once we have understood what they want to know, then the next step is you have to tell them, well, your report has come and I want to give you some more information regarding the same. Is it all right if we talk now, or you want to do it some other time, or you want to call somebody else? Because then we will have to plan it further. It gives them in your own local language, however you want to say it. It gives them enough indication that things are not as simple as, because I am myself taking a little more time to spell out those things. So it's called a warning shot. Right? So once they have understood that and they are ready for getting new information, and they have had either a sister or a brother or a father, somebody next to them. Hello? Hello?
Ma'am, please continue.
Yeah. So then we have to share the information. And the way you have to share the information is to say this and then stop. Check what patient has understood. It is possible to explore concerns while giving information, and we have to pay attention to their emotions while we are talking. Painful concerns may remain invisible, but they need to be probed. And this is, this is just a guideline about how you want to go about it, but you will have to see it done repeatedly and try it doing again and again, then to be better in giving this bad news. So you have to be clear, you have to be gentle, and you have to be slow. So for example, if that person who has come back, I have to tell him, after making sure that he has his brother or somebody by his side, that okay, that why I had sent you for the biopsy. Okay. And now the report has come, and as I feared, it says that it is cancer. So what is he thinking parallelly as you say this? That this doctor's doubt was right. That is one thing. My cancer is confirmed because maybe some other doctor had said it. The next question would be either he will be shocked, or he will be angry, or he will be in disbelief, or whatever, that we will see about his reaction. But you have to be clear what you want to say. You want to be very, very gentle. Just don't throw the information at him. And you want to be slow so that you understand that he understood the thing. Got it? We don't have to minimize the severity while we are talking about it. We will have to respond to their feelings as per their emotions, and they could be very different. As I said, somebody may react in anger, get up and go away, or some may just become numb and start crying, or somebody would just say, do you want to take another opinion? Whatever it is, we have to give them time to react in their own way. We have to listen to what they are trying to say. And through non-verbal communication, maybe a pat on their back, give them a feeling that in these difficult times, we are with them. That's, I mean, it's not compulsory that you have to do that. Sometimes you don't need to do that. But if you feel appropriate and comfortable, even non-verbal communication plays a great role. And after telling this, you cannot be leaving them like that. We have to plan and follow up. How would you do that? Once you have told that, it's your responsibility to tell them, okay, this is a cancer. You will naturally know whether there is a staging done, grading done, that needs to be done, whether it has already been done and they have come back with that, and if they need a surgery or a chemo or a radiation, or it is in a palliative state. So you need to know this case very well before you talk. If, let's say, if the patient is in a palliative state right at the diagnosis, then you will have to say, okay, this is the diagnosis. You may need help for, like, if it is oral cavity cancer, then if you have to have difficulty in swallowing, what are the other options? If you are in home setting, what we can do, how your team can help, how the pain can be lessened. All these things you will have to put down and explain it to them. He may or may not be in a situation to take all that information, but maybe the person next to him would require that information so that he can come back to you. And always before leaving that interview or communication session, you have to give the contact information if they want to ask any more questions or they need some clarification about something. Does it make sense? So there are many protocols people using in giving breaking bad news. Actually, breaking bad news sounds very direct, but we now say that communicating bad news. And the way we break bad news or communicate bad news, there is a protocol which is routinely used essentially of these steps, is called Spikes protocol. And the objective of this protocol is to gather information from the patient, giving medical information to them, providing them the support, and eliciting the patient's collaboration in developing a strategy or a treatment plan. See, we can decide it for them, but that's very, very paternalistic. We need to understand their wishes once they understand what is happening with them. So spikes stands for setting up the scene, perception, understanding the perception, inviting them, I mean, understanding how much they want to know, what they already know, supporting them with their emotions, and then planning a strategy or having a plan and following it through, right? So, couple of questions at this point, or we can take it later on. We have to finish another small thing before 4 o'clock. If there is any burning question at this point, I can take.
Madam, I have a question. How can we communicate a patient about cancer at the cancer in the fourth stage? That is with the meds, like cancer with the meds. How can we communicate the bad news?
No, I didn't get your question completely. What you mean to say is patient has come to you for the first time,
The patient,
and they already have a stage 4
unfortunately,
cancer.
Madam, unfortunately, the patient was my wife.
Uh-huh.
The first diagnosis was leg cancer with the meds. That's all over the body in the fourth stage.
Okay.
At that stage, how can we communicate the bad news? I
So,
had managed it. If I may be wrong or right, I think I don't know, because
So,
I am the only veterinarian participating in this group. Only veterinarian.
only?
Veterinarian.
Okay.
Veterinary doctor.
Okay. So you have already done it, right?
Yes, madam. I
So-
think I may be wrong.
Oh, would you like to share what you have told?
I straightly shared all the matter to my in a smooth language, patiently, by listening all her emotions. There was no irregular or spontaneous reactions in it. Not felt lonely in her. That was my experience.
So, I mean, sir, I don't even know whether you had to break that news or your doctor or any healthcare professional should have done that.
Yes,
Because you know, as she was tense, I'm assuming you were also under the pressure and knowing all of it together, right?
I took a scan from a private clinic. Then
Okay.
the clinician told me that it is cancer. The cancer is in the fourth stage itself. Then I was forced to tell her in the evening after the office hours. That was happened.
But I mean, see, whatever has happened, but for others, I think if something like this has happened and you are not a medical person, or sir, at least you are veterinary doctor, so you can take that responsibility. But I think safe would be to say that, okay, reports are there and we understand something, but not surely. Let's go to a doctor and find out.
Yes. Thank you, madam.
And if doctor would have explained it to you instead of patients, then you can come back and say that you know, we don't have a good news and doctor spoke to me about this and this.
Of course, madam.
Yeah. Okay.
Thank
Thank
you.
you, sir, for sharing. Thank you. So coming to another topic called collusion, and as I said, collusion is information about diagnosis, recurrence, prognosis in the advanced terminal stage of the disease, and medical details about the deceased person withheld from the significant person. I mean, not to tell the patient about his or her diagnosis. Yesterday night, I was called by my son's friend's mother to come and see her mother-in-law, my son's friend's grandmother, who was diagnosed with pancreatic cancer. She's been in the hospital, she has taken some treatment, and now doctors have said that because of her age and there was poor response, now there is no more curative line of treatment. She's come home and she has terrible pain. And this, my son's friend's mother calls me and tells me that you come and see her. The only thing is, I have not, or we have not told her about the diagnosis. The moment I went and started talking to this old lady, she already knows me. Immediately she asked that so many tests have been done, so much of a treatment has been done. What is happening to me exactly? What do you do then? I'm sure you must be facing similar situations. So we will see how do we learn about, understand about collusion. So collusion is keeping that information, significant information, away from this person who is part of it. But we have to remember that it is also an act of love. So collusion can occur between professionals and relatives, relatives and patient, and in between relatives. Like if there are two sons and the father is having cancer, one is in America and the other one is looking after father. Father sometimes tell the son who is here that don't tell him all the things. He may be shattered there. He's alone. Or sometimes relatives come and tell us that don't tell the patient. When I was working abroad, patients have a right to know everything, but here in our scenario, family plays a bigger role. And why are they having this collusion? We have to understand that collusion most of the time is all about with good intentions. They want to protect their loved one and they want to protect them from the distress which will occur out of understanding what they are going through. Like yesterday's case, this friend of mine or my son's friend's mother was thinking if the old lady finds out that she has cancer, she will give up eating and everything and supporting to any, I mean, she will not respond in a positive way because her husband has also died of cancer. They may fear that patient may give up, similar to what I just said. And it's a belief that patient may not be able to cope with the truth about poor prognosis. There are other reasons for collusion which are not so important, but we need to know that it could be a possibility not to reveal because of some financial concerns, advantages to one party, not to the other party. And if old parents are there and one of them gets the cancer, we are really worried about the other elderly person in the family. You can't really have bandwidth to tackle two old patients at one point of time in the house. Sometimes there is a social stigma. They don't want us to call it as a cancer word. And there is sometimes lack of awareness. But what happens is that honest communication between these three parties, whoever is colluding, the honest communication is hampered. There is a lot of distress. And in the bargain, we lose a lot of precious time. Patient is isolated. Sometimes they are angry, guilty, frustrated, and they don't believe in their own near and dear ones. Sometimes they have, if they know that they have limited time, they can finish the unfinished businesses. But because of collusion, they just don't know. It is not openly said, and therefore those remain incomplete. Here, if you imagine patient doesn't know and families are telling us not to tell, both the parties are grieving, but they are alone. They are not together in this. There is a constant stress and burden of hiding the truth. It doesn't give peace to anyone. There is inability to eat, sleep, communicating with others because all the time that hush hush talk goes on. And in the bargain, patient feels out of control or maybe trapped. They don't know how to react. Okay, I am just going to the next. How do we manage? As I said, using that 6-step protocol or spike protocol, you can acknowledge as a doctor there, you can acknowledge if the relative tells you that not to tell to the patient, we will say, okay, but why do you think that it is not good for her to know? We need to explore their reasons. As I said in the other case, the young patient had CA breast and her mother had CA breast and her aunt had CA breast, and she had those impressions. So she was not consenting to the treatment. So maybe similar things happen with relatives, that somebody has not reacted well to the information, so they don't want to disturb their patient. But the way to deal with it is with relatives' consent. We need to elicit, when we are talking to the patient, we need to elicit their worries and questions regarding the illness. We have to give the feedback to the relatives. See, what happens many a times is when you go to see patient, when you are examining them, that is the time patient catches you alone and they will say, doctor, मुझे कैंसर हुआ है क्या? Then telling them, no, you are all fine, is wrong thing, no? I generally tell the relatives that I understand your worries. I very honestly try and tell them why it is important for patient to know what they are going through. You know, it is not important in one go to tell them that you have stage 4 cancer, but they need to know that they have cancer. And I also tell them that if patient asks me directly, I won't be able to lie to the patient. Many a times when I start with the interview and when I say that tell me how it all started, somewhere on the course they will say that डॉक्टर साहब ने बोला था ये ट्यूमर वापस आ गया तो समझो कैंसर है. So, you know, they already have some idea about something not happening right with them, progressing it despite treatment. And we have to get through communication, we have to get to a point that that information comes out rather that we directly going and giving it in one sentence and running away. So we have to explain to the relatives the importance and reassure them, and we have to be honest in telling whatever we are going to talk to the patient. And we have to encourage the dialogue between patient and relative. We have to remember to value statements made by family members as their previous experiences, understand their emotions, listening to their concerns, then telling them or understanding patient as a person, how they have responded to bad news earlier, what kind of a person they are, and then be ready to answer questions from patient and the family. It is not as easy as we are talking or seeing it here. We have to review whatever we have talked, like, did I listen? Did I explore their beliefs? Did I make an acceptable working diagnosis of what's happening between them? Did I share options for investigations whenever required? Did I share the decision making? And did I make some attempt to see that my patient understood any communication? You have to check back whether they have understood it correctly. And all important is, did I develop a good relationship with my patient, with my family? It is best learned through experience. Identify our own skills and try to refine them. Identify our shortcomings and try to overcome them. There are no fixed guidelines. These are just rough ideas about how you can go about. The communication should be patient-centered, including their own cultural beliefs. In their context, we have to talk. Accept our limits. There is no role model, but don't assume anytime. I think it's 4 o'clock and I'll stop here and I leave it to others to take on.
Thank you, ma'am, for that presentation.
Should I just stop sharing?
Yes, ma'am, you can. Yes, ma'am.
Yeah.
Ma'am, we have a chat in the box that from Shashtavisa Majumdar that what are we supposed to do if even after that family still refuses to let the patient know?
Sorry, I didn't get the question.
What are we supposed to do if even after that, explain all those details, family still refuses to let the patient know?
Okay, I'm assuming that even after we explained everything to the relatives, family still says that you don't have to.
Say,
Yeah, so I think very few times the situation occurs. It depends on your communication with the relatives, telling them why important it is to talk to patients. But still, if they insist, in my so many years of practice, I can pinpoint those patients or families who have said, come what may, I don't want you to talk to my patient about this. Then you have to honestly tell them, sir, in that case, I won't be able to do honest justice to the patient. I will have to be limiting myself of giving the further treatment. Is that okay with you? I think sometimes family understands that once they get trust in you, they understand what is this doctor talking about. They will think and come back to you. I can share with you one example that there was a lady admitted with us and coming from a very illustrious family, but she was uneducated and she had 4 children. All of them, they came and said, we will admit our mother for pain management, but she shouldn't know that she has cancer. We said, don't get her here because she will surely understand that she has cancer. And even if we don't tell, some next neighbors, relatives, somebody, next patient, somebody might just say this because it is cancer palliative care center. So couple of days later, one son came and said, one of us will be all the time with her. But it was a female ward and they were 4 sons. So they said, okay, we will have one of the daughter-in-law accompanying her all the time. And then, exactly as I said, I told them, if your mother asks me directly, I will have to tell her the truth. But why don't you come with me when I'm talking to her? And I went, sat next to her, and I said, tell me how it all started. And she said the same thing, that when I had pain in abdomen, I went to so and so doctor, he operated, and he said, if it comes back again, which means it is cancer. So I said, what did he tell you? Then reflected back, and then she said, हाँ उन्होंने बोला था कि if it comes back, it is cancer. So she knew, and the son looked at me and I looked at him. So, it was like son didn't know that mother knows. And then we asked her, what do you want us to do now besides pain management? And the interview went on other things. So I hope you got the answer.
I think Isha Bista also, and one more person also raised their hands.
Sure.
Isha Bista, please.
Ma'am, what do you do when the patient is a child?
So how old is the child makes all the difference.
Around
So-
maybe 10 years, or a child and adolescent as well. 2 questions.
Sorry, say it.
2 questions for children and also for adolescents.
For
Because
the
parents for 2 questions, one for child and one for adolescents, because usually parents don't tell them. Adolescents sometimes figure out because it's an oncology ward and then they research, so they get to know.
So for adolescent patients, we generally say that concept of death is formed around age of 8.
Yeah.
So, they know that. So again, you have to go to their level and understand what is their understanding. That is most important. And build it from there. Right? And if they are like 11, 12, they're as good as big kids. They would discuss with you. They would say, if you spend time with them, they would say that I had one patient called Shraddha, and she said, you please tell my brother that he can have all the things to him, but share those with me right now, because once I am gone, it all belongs to him. You know, they understand. I think the key is you need to spend enough time with them to understand how much they know and what they know, and build it from there. Yeah.
And
So-
also, usually parents hide it from them. They
Yeah,
tell,
so
"Don't-
again, the
don't
same
tell."
thing. You will have to educate parents first. See, you have to understand that you will tell them and go away, but parents are there. They have to manage these kids all day and night. So without their consent, without they become a partner with us, I don't think we should be doing this. But our job is to convince parents first. Yeah. So there's another person raising the hand.
Yes, Shata's.
Yes, ma'am. Ma'am, the last question was also asked by me about that, like even after telling all these things, if the family refuses. And ma'am, I have another two questions.
Can you be little
One
louder?
is, yeah, just a second, yeah.
Yes, am I able now? Yes. Ma'am, one of my questions is that, like I am a clinical psychologist right now working in a cancer hospital. So I am at times oncologists call me for consultation of patients, the patients who have been undergoing treatment for quite a long time, like 1 year, 1.5 years. And right now, when I talk to them, I find out, in most cases, I have found out that the family and the patients both are not very much aware of what is going on, the severity, the prognosis, and now a significant period has already passed during treatment process. So now if they are not totally aware, then how to deal with that situation? And now they are asking that, like one patient was there who was undergoing curative treatment first, but now the patient has entered palliation.
Yeah.
But the family is not clear about it. So they are like, patient was improving before, suddenly what happened? And why weren't we informed before? Like obviously the doctors have definitely explained to them, but probably due to denial or some other factors, they were not able to totally grasp the severity of the situation. So right now what I experienced was that thing, the fear of being blamed, that suddenly the patient is like deteriorating. What happened suddenly? So I find it very difficult to manage in such situations, that
Yeah,
what to answer, how to.
Yeah, I can understand where you come from. But the thing is, in busy hospitals where doctors have limited time, I think your role is very, very important. Once you understand that, I think the first step is to confirm with the doctor, treating doctor, that this is the stage. And if family talks to me, can I share this with you? So when you're gathering the facts, you have to be solid understanding about the where they are currently. Okay, that is stage one. When you're talking with the relatives, you have to say, you have come suddenly into picture, right?
Yes, exactly.
So you have to then tell them that before coming and having a talk with you, I have just confirmed with the treating doctor. They have told me what all happened in last 1 year or 1.5 year. Initially, they said that you were responding well to the treatment or whatever it is, but slowly you have come to a stage where we are maintaining it. I mean, don't say palliative immediately, but they are doing the treatment for the maintenance. I'm sure you understand this. Say
Yes,
this,
ma'am.
stop, ask for their input. They will say, no, nobody told us that. So you said you need to go to your doctor and reconfirm it because they just told me. See, that absolute clarity in the story, what you're narrating, is important. And it is your responsibility that you get those facts in line at very first time. And then
Ma'am,
build
I have
on that.
another
Yeah.
Okay, ma'am, I have another question, that patient and family both are knowing the diagnosis and prognosis. But now some new advancement has come into the picture, probably some new about metastasis or anything new has happened, and now the family is not willing to let the patient know about this new finding, though the patient knows about the diagnosis of cancer, but about the new advancement the family is not willing to let the patient know कि इनको मत बताइए, उनको इतना ही पता है काफी है. Then what to do in such situations?
So again, as I said, go through the same protocol of getting relatives on your side. And usually they have some story, what is stopping them from letting this patient know. You have to also, as a professional, understand their reason, validate that, acknowledge that with the relatives, and still be able to tell them why it is important for patient to know. Because they will have some unfinished businesses which they need to complete.
Okay, ma'am, I had a question.
Yeah.
So, what I think that, let me know if I'm wrong. Instead of creating a situation where there is a collusion, where the family is not permitting us to talk to the patient and let the patient know, is it acceptable if we talk to both patient and family together? Like this is usually done by doctors. But instead of first informing the family and then the patient, regardless whether the patient is minor or above the age of 18. So can we do something like that?
See, it depends on what kind of a practice or what kind of a culture in which you are working. So are you pediatrician by any chance?
No, ma'am, I'm a social worker.
Okay, but dealing with children?
Not particularly, but all people.
So if you understand the scenario, generally when patients are brought into the hospital, generally they will say, you sit outside, we will talk to the doctors. So our practice is like that, and you cannot suddenly over the day change it. It's a thought process which needs to be changed slowly but surely. Yeah.
Thank you, ma'am.
Ma'am, thank you, ma'am. Thank you for clarifying the doubts. And
one more doubt, madam. One more doubt.
Sure.
Sir, can you use the chat box to, sir?
May I continue?
I think there is a lack of time now. You can write it there or ask me. I'll speak to you later, sir.
Sir, you can drop the question in the chat box and we can discuss it later. We have a case presentation now, so we are running out of time. That's why. So, is that okay, sir?
We do have a case presentation by Ms. Meghna today. Meghna, over to you.
Am I audible?
Yes, yes.
Okay. Good afternoon to all. And moving on to my case. I am dealing with the case. It's a 43-year-old lady, and she was diagnosed as cancer, colon cancer, and it spread to her brain, and she's not employed. The medical history. Patient reported with abdominal discomfort and fatigue. The doctor referred her for further treatments. When she experienced the discomfort, and then referred to the doctor, and also she has symptoms related to that, and she was undergone colonoscopy and diagnosed it as colon cancer, and started the treatments, therapies, and at RCC. And the patient was not aware about the diagnosis and the treatments because she's also having a psychiatric issues, and the brother is partially aware about the diagnosis, and the prognosis is also not aware about the patient, and the families from the side of the family, they have a little knowledge related to that, and the palliative care services, they are not clear understanding related to that. They were aware about the palliative care services are providing in our society, but they have no other knowledge related to that. This is family overview. The patient's father and mother had passed away, and she only have a brother, and have a good or a strong bond with the brother, or the emotional relationship with the brother only, and they are not having a close relationship with the family relatives or other members. This shows the eco map and the patient related to the panchayat, because they were receiving the support from the panchayat, and also some also receiving, or their treatment is going with the RCC and the institution. They are the patient is having a psychiatric issues, so she is living in a rehabilitation center, so they receiving the support from the institutions, and a small support is also giving receiving from the relatives also. Socio-economical overview. They are having poor socio-economic background, and they are having the BPL category, and they live in a small shed without proper facilities, and they financially very weak and find difficulties for her treatment. And the brother is the primary breadwinner of the family, and he is not having a proper job. He's a daily wage worker. Psychological overview. The patient, she was having schizophrenia and undergoing treatment for the past 10 years, and the low self-esteem, and the patient is depressed and irritable due to the physical and psychological conditions. The physical pain that the patient is undergoing: fatigue and body pain, constipation, stomach pain, weight loss. And the psychologically, she was having anxiety, delusions, and frustrations, and the spiritually depleted, faith in God, not able to involve and create joyful moments with others. While in the rehabilitation centers, other inmates are involving in the activities, but she is not able to involve in the activities or programs due to the physical difficulties and all. And socio-economically, no proper housing and financial instability, no proper occupation or job. Next, okay. And the discussion points that I added here is awareness regarding the illness and the best treatment facilities available, because the patient and the family is not aware about what the disease or what all are the treatments that is available, and the facilities, etc. And the role of institutions in providing palliative care. The patient is living in a psychiatric institution, and the institution is providing support to the physical issues, like the cancer treatment is providing from the part of the institution. So how these two is managing by the institution. Okay, these all are about my case, and thank you.
Thank you, Meghna, for presenting that wonderful case.
Hi, Meghna, anything about this inside? Hello?
Yes, ma'am.
Can you why is she has no insight on diagnosis or prognosis? Is there anything to discuss in this?
Yeah, she's having schizophrenic disorders, and already we know that the psychiatric patients insight about this diseases and all were very less, and she is unaware about all these kind of things, and she is not properly responding to us. The brother is also not fully aware about what is the diagnosis. Sorry, ma'am, I couldn't hear you.
I'm sorry. Will you able to follow it up, like to complete the awareness on diagnosis or prognosis?
Partially, I'm able to provide the awareness, and then I found some changes related to that.
Okay. So what about palliative care? Like providing information about palliative care and the facilities available.
Yes, they have a connection with the panchayat. They were connected to the panchayat and ASHA workers. So they know what they know about the palliative care services are existing in the society, but they were not aware how to connect these two. So I can provide some little knowledge related to that, and I connected to the ASHA workers, and they received the palliative care services.
Okay, thank you. So as she says, schizophrenic patient, it might be difficult to communicate all these things, right? And only has a brother to communicate all the prognosis or palliative care and all. Is there anything to be added related to our today's session with this?
Madam, one question. This in this presentation, spirituality is not properly addressed. It is something related to God only, not related to God only actually. So many more things also. That more explanation, please.
Sir, I think we have one more session on spirituality, particularly on spirituality, so that all of the participants can have better knowledge, can get a better knowledge about spirituality.
Okay. Thank you.
Thank you, sir. Do we have anything else to discuss regarding this? And if not, I think we can wind up the session. We had a wonderful session today.
But I would want to ask something.
Okay, ma'am. Okay, please.
If a person has some psychiatric illnesses, I don't think breaking bad news would actually help the person, depending on the insight, understanding level, and the current functioning and thought process, cognitive functions of the patient.
Yes.
So if a person, like even anxiety, depression, and all is very common in a psychotic patient because of the delusions the person is facing.
Yeah.
In such situation, I don't know, even taking the person to palliative care might be difficult, depending on what the thought processes are.
Yes.
So what can we do in such situations?
In psychiatric patients, it is really difficult to convey the information about their diagnosis, prognosis, or the clarity is, the part is that their cognitive part is impaired and affected. So we cannot relate to anything else. So we cannot communicate it properly. So once the psychiatric treatment and all goes on, or better, we can deal it with a psychologist and a psychiatrist in more detailed way.
Sometimes, not always, it takes a very long time for the schizophrenic episode to get over. In a certain number of cases, they don't. It continues. Changing the setting of the patient's residence might be a big challenge. Like, because the person's already in an institution right now. So what can we do in such situations? I don't know.
Sorry, can you once again, can you just explain that? What is the situation?
if the
Yeah.
person is living in a organization or an institution right now
Okay.
for palliative care,
Yeah.
I am not sure if palliative care can be provided in the institution itself, because the aim and the vision of the institution is very different.
Yes, 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 definitely, definitely.
And changing the residence of a person might be very challenging if the person is schizophrenic, especially depending on the delusion of the patient. So
Definitely.
in such situations, what can be done? Like, I know that you can tell the brother, you can educate the brother about
Yes.
everything, but
Yeah.
to get the patient to be a little, comply a little bit might be difficult, because changing residence might be a very violent thing to do at that time.
Yes.
So what can you do?
We cannot do anything in that situation. Instead of getting advice from the psychiatrist or the psychologist, unless and until they are subsided with their symptoms, we cannot deal with it actually. So, and we can provide home care treatment as well, like visiting the organization with the palliative care team, with the doctors, nurses, and the social worker or psychologist. We can visit the organization and we can do the palliative care there. But communication is really difficult with the patient.
Thank you.
I think we can wind up the session. If you are having more questions, you can put it in the WhatsApp group, or you can message me. I will contact with our faculty and will let you know the answers. Thank you all for joining us today. Your feedback link will be shared in your WhatsApp group. Thank you all for your time. We'll see you on the next session with another topic. Bye-bye.